Hi, my name is Wumi with Minimize Learning, and I would like to welcome you to our YouTube channel. We've created this channel to make for a better learning experience that goes well beyond the scope of Instagram. The idea is to be able to make longer and more comprehensive videos to engage with you guys better, to answer questions, to get helpful suggestions on the topics that you would want us to talk about, and just make generally better content. So I hope you guys subscribe, share, and turn on post notifications so you're aware when new videos are uploaded. The first video is up, and I really hope you enjoy it. It's great to have you on board. So, talk about supply to the brain. This is the circle of Willis. In the circle of Willis, we have the anterior circulation and we have posterior circulation. Right? The anterior circulation is typically made up of the anterior cerebral artery, middle cerebral, and the lenticulostriate artery that's not here. So right here we have the motor and sensory homunculus, which we also talked about in the last tutorial. And just a little bit of that is anterior cerebral artery mostly is lower extremity stuff. So it means that if you have a lesion in the ACA, you find symptoms here. If you have lesions in the MCA, you find symptoms here. And this is the PCA, which is posterior circulation, which is part of what we want to talk about today. So if you find stroke questions typically to be very convoluted, I used to think that stroke questions were convoluted. So if you find stroke questions to be convoluted, like if you see a stroke question, you're preparing for Usmle, PLAB, or MCCQE, and you do like a little eye roll or you get a bit flustered, then this video is for you. So get a pen, get a pencil, get a note, popcorn, whatever it is that you guys used to study. And let's get into it. So we're going to talk about the rule of fours. So the rule of fours is a rule that was established and developed by a man called Peter Gates, good guy. And the essence of the rule of fours is to deconstruct or demystify brainstem strokes. Now, usually when we see questions on brainstem strokes, and this is something that I think that people use in practice as well, there are different things, there are different symptoms that we find, right? For cortical strokes, they're a bit more straightforward. You have either weakness, paralysis, sensory loss, and that's usually it. As a principle, I always say that once you find one or two cranial nerve deficits, assume that it's a brainstem stroke. Something is happening in the brainstem. And that's because, as we would see later on, the cranial nerves are distributed across the brainstem. So usually if you have a pure motor stroke, a pure sensory stroke, that's usually higher up, usually something cortical or in the internal capsule, right? But once you start seeing cranial nerve deficits, then you start thinking of brainstem strokes. And I like to keep it as simple as that. Obviously, with medicine, there's usually these weird exceptions here and there, but I like to keep it as simple as possible. And usually for these exams, they like to keep it as simple as possible too. They might try to condense it somehow, but it's usually pretty straightforward. So when we're talking about the rule of fours, what it does is it takes the brainstem and we divide it into the three parts that we usually talk about. So the brainstem is this, right? And part of the brainstem we have the medulla. This bit goes into the spinal cord. This is the medulla. We have the pons and then the midbrain. So these are the three major parts of the brainstem. What the brainstem does is technically it underlays the cortex, connects it to the cerebellum, and then to the spinal cord. So each tract that is passing either descending or ascending will pass through the brainstem, right? How it's now distributed across the brainstem, how it is distributed across the brainstem is what we're going to talk about now. So this is what the rule of fours is. So again, remember, typical stroke rules is that anything that happens above, any lesion is above a decussation would have contralateral symptoms. This is just one of the major rules, right? And that's because we have above the decussation crossing. So with the motor pathway, the medial lemniscus pathway, the spinothalamic tract, any lesion that is above the decussation where the fibers cross would always have contralateral symptoms. For the sake of answering exam questions and really in live, I always think of every higher than spinal cord level pathway lesion as contralateral, right? It just keeps it a bit easier that way. So above decussation, contralateral symptoms. Once you start seeing cranial nerve deficits, start thinking brainstem. So there are vascular syndromes for stroke in the brainstem, and that is really what Peter Gates tried to deconstruct by putting this rule of 4's into place, because it kind of helps neurologists, non-neurologists, medical students. It simplifies it a little bit. So the first thing is, so again, rule of 4's. All right. So the first rule in the rule of 4's is that there are 4 structures that cross through the midline, starting with the letter M. This is important. The first rule is that there are 4 structures that cross through the midline and that start with the letter M. The first structure is the motor pathway. So motor pathway is really the same as cortical spinal tract. All right, but to keep the mnemonic and to keep the rule simple, motor pathway starts with the letter M. That's one. The second structure is the medial lemniscus pathway. Which is also called the dorsal column, right? This is the second structure. All right. The third is a medial longitudinal fasciculus, also called MLF. So what the MLF is, and I won't get into, maybe we'll do a separate video for this at a later time. What MLF is basically a structure that connects the cranial nerve 3, 4, and 6. These are the cranial nerves that control extraocular movements. So basically, the MLF integrates the eye movements and head movements. It's the MLF that tells the eyes which way to look when you turn your head. So if you turn your head this way, your eyes kind of follow through. It's the connection between the MLF and these nerves that do that. Yeah. Anyway, so that's the third structure. The fourth structure here are the medial or motor, terrible spelling, medial or motor cranial nerves. And these are cranial nerves, well, the nuclei of cranial nerves 3, 4, 6, and 12. All right, so this is the first rule of 4's. There are 4 structures that cross through the midline, starting with letter M. The motor pathway, or the cortical spinal tract, medial lemniscus pathway, or the dorsal column, the MLF, which is the tract that connects 3, 4, and 6, and the medial or motor cranial nerves 3, 4, 6, and 12. That's rule number 1. Rule number 2 is that there are 4, so that's the first one. Rule number 2 is that there are 4 structures to the side, starting with letter S. Okay, so first is starting with letter M. Second is starting with letter S. So the 4 structures to the side that start with the letter S are: 1 is the spinal cerebellar tract or pathway. 2 is the spinothalamic tract. So spinocerebellar tract is related to the cerebellum. So as you can imagine, balance is important there. Spinothalamic tract is what is responsible for conducting pain and temperature. All right. The third structure is the sensory nuclei of cranial nerve 5. So cranial nerve 5 is a trigeminal nerve, and there it has a sensory motor side. All right. So the sensory nuclei of cranial nerve 5 is to the side. And the third structure, starting with the letter S, as sympathetic fibers of the sympathetic nervous system. So this is rule number 2, all right? So rule number 2 is 4 structures to the side, starting with letter S. Rule number 3 is that there are 4 midline cranial nerves. 4 midline cranial nerves. And these 4 midline cranial nerves, they divide into 12. So basically, it's a bit of maths, but it just means that the 4 medial cranial nerves divide into 12. So this is, and the exception to this rule is except 1 and 2. So there are multiples of 12 or submultiples of 12. So that's cranial nerve 3. And basically this rule and this rule under here, that's this one, kind of there is an overlap there because it's the same one. So the 4 midline cranial nerves divide into 12 except 1 and 2. That's cranial nerve 3, 4, 6, and 12. Again, that's what we have here. It's the 4th rule under the structures that go through the main line starting with letter S. Oh, I'm starting with letter M. What did I do? Starting with letter M. All right. So that was a mistake. I think I made a mistake here. Starting with letter M. So this is rule 3. You have 4 midline cranial nerves that divide exactly into 12, except 1 and 2. That's cranial nerve 3, 4, 6, and 12. The last rule here rule number 4. So rule number 4 is that there are 4 cranial nerves in all 3 parts of the brainstem. So remember that we said that the 3 parts of the brainstem are the medulla, pons, and the midbrain. So the rule of 4's divides the cranial nerves into those parts. So we have 4 in each part, making 12. So what that means is in the medulla, so I'm going to start from rostral to caudal. So in the medulla, we have cranial nerves 9 to cranial nerves 12. To go above the medulla, we have in the pons, cranial nerve 8, actually 5 to 8, cranial nerve 5 to cranial nerve 8. And in the midbrain, so in the midbrain, we actually have cranial nerves 3 and 4. If you remember the way the cranial nerves are distributed, you know that cranial nerves 1 and 2, so above the midbrain, you have cranial nerves 1 and 2. So what I can do here is bring this here. Okay, so this is a brainstem now. So remember we said that each part of the brainstem has 4 cranial nerves, so 4, 4, 4. So in the medulla we have 4 cranial nerves 9 to 12. So this is medulla here, cranial nerve 9, that's the glossopharyngeal, vagus, hypoglossal, and accessory. This is the medulla. If we go above the medulla, then you expect to see cranial nerve 5 to 8. So starting from, this is the pons, right? So from here, so we have trigeminal nerve, abducens nerve, facial nerve, and then in the cerebral pontine angle, you have the vestibulocochlear nerve. Then above the pons, you have the midbrain. We have cranial nerves 3 and 4. So that's the oculomotor nerve and the trochlear nerve. Above the midbrain, you have optic nerve and olfactory nerve. So olfactory nerve is not shown in this picture, where it comes down like this. If you remember, it usually looks something like this. So that's olfactory nerve. So this is how these cranial nerves are distributed. The essence of knowing this is if you find a patient and they already have signs of a stroke, right? And they have cranial nerve deficits, you already know that this is a brainstem stroke. Now, depending on how you work with these rules, you can now determine which part of the brainstem is affected. Now, in clinical practice, you would still have to do a CT scan, right? But this just helps you to kind of know. And I think, honestly, I think right now it's more important for like passing your exams and stuff. So other things that to remember here is we've said that the midline, the cranial nerves that go through the midline are the ones that are multiples of 12, except for 1 and 2. So you take away 1 and 2, that means you have 3, 4, 6, and 12 itself. So again, midline cranial nerves, that is cranial nerve 3, once again, midline, cranial nerve 4, cranial nerve 6, and cranial nerve 12. So these are cut out and it would not show exactly how it is, but these are part of the midline cranial nerves. All right, so now to use this information to answer questions, this is a bit convoluted, but the idea is to be able to use it to answer questions on stroke and the brainstem, vascular syndromes. Some are more common than others, but so just let's go through that again. First rule of 4 is 4 structures cross through the midline, starting with letter M as a motor pathway, medial lemniscus pathway, medial longitudinal fasciculus, and the motor cranial nerves of cranial nerves 3, 4, 6, and 12. The second rule is that there are 4 structures to the side in the brainstem that start with the letter S: the spinocerebellar tract, the spinothalamic tract, sensory nuclei of cranial nerve 5, and sympathetic nerve fibers, the fibers of the sympathetic nervous system. There are 4 midline cranial nerves that divide into 12, except cranial nerve 1 and 2, which is a bit of a repetition, but that's cranial nerve 3, 4, 6, and 12. And there are 4 cranial nerves in the medulla, 4 in the pons, 4 in the midbrains, with really 2 above the midbrains. So 3 and 4 in the midbrains, and 1 and 2 above the midbrain. So what we're going to do now is try to use that to answer questions. Okay. So the first question is: there's a 65-year-old man is brought to the emergency department by his son. He's reported to have been unstable in gait in the past 24 hours, and he has complained of right facial numbness. On further examination, there's loss of pain sensation on the left, but preserved fine touch and proprioception. There's also decreased gag reflex. Where is the most likely location of the lesion? So the way I would say to answer the questions is to first of all make note of the symptoms that are there, right? So on instability in gait can be one of two things. If you a person has so instability in gait is ataxia, right? So there are 2 types of ataxia. There's sensory ataxia and there's cerebellar ataxia. Now there is clinically you differentiate that during the Rombeck test, right? You tell a patient to stand, tell them to close their eyes, and all of that. However, if you're doing it just like this, if you have instability in gait that is due to a problem, so if we have this here, we have ataxia. If ataxia is sensory, it means that this is a problem with dorsal column. So if it's sensory, this is a medial lemniscus dorsal column problem. If it is cerebellar, then it's cerebellar, right? However, if you have a problem with the medial lemniscus dorsal column, you would also have a problem with fine touch and proprioception. So if fine touch and proprioception is preserved, let's assume that this is no longer a sensory issue. So this is something with the cerebellum. All right, so this is one. So this is one symptom. We found that there's something with the cerebellum. The other thing is facial numbness. Facial numbness and facial sensation generally is a function of the trigeminal nerve, right? So that's cranial nerve 5. So we've recognized that there's a cranial nerve deficit. So now we're thinking of brainstem strokes. We now have to decide on where is cranial nerve 5 in the distribution of the brainstem cranial nerves, right? So remember, 1 to 4 is in the midbrain, 5 to 8 is in the pons, right? So now at this point, we're thinking pons, right? So we're just going to put a star there and think pons. There's also decreased gag reflex. Gag reflex is cranial nerve 9 and 10. So there's an afferent and efferent limb for gag reflex. Part of the gag reflex is studied by the glossopharyngeal nerve, part of it by the vagus nerve. So these are two nerves, right? And if we think about the cranial nerve, 9 and 10 should be in the medulla, right? So we're seeing pons and we're seeing medulla, but we're thinking of just one lesion. But if you remember here, this part of the cranial nerve is the sensory part, right? So if this is the sensory part, we said that the sensory nuclei of cranial nerve 5 is where? So we'll go back to here. Sensory nuclei of cranial nerve 5 is lateral. So this is a lateral problem. It's a lateral problem. So this is not the entire cranial nerve 5 itself, it's just the sensory nuclei. So now we're not thinking that it's pons, we're thinking, okay, this seems to be more a medulla problem, right? Because we have these two cranial nerves here, we have a medulla problem. And we're thinking that it's sensory because we're thinking that it's a lateral medulla problem because we've seen that cranial nerves 9 and 10 go laterally because they don't divide into 12. Remember, the midline cranial nerves that go in the middle will divide into 12, 3, 4, 6, 12. All right, the cranial nerves 9 and 10 will be on the lateral side. So this is a lateral medullary lesion. This is also called Wallenberg syndrome. Wallenberg syndrome is when there is a lesion in the vessels that supply the lateral medulla. The particular vessel that we're talking about here is the posterior inferior cerebellar artery. That's pica. That's this one. So pica supplies the lateral medulla. Pica supplies the lateral medulla. So this is a lateral medullary stroke, okay, or lateral medullary lesion. Once again, the way that we got here is we've isolated that there was a cerebral problem, and if you here in the name pica, C is cerebellar. So this vessel also supplies part of the cerebellar peduncle, and that's why this patient had ataxia. All right, but yeah, apart from that, there was facial numbness, and we said facial numbness is a cranial nerve 5 issue, and cranial the sensory nuclei of cranial nerve 5 is on the lateral side. So we're thinking more laterally now. All right. Now we said that there is also decreased gag reflex. Gag reflex is a function of cranial nerve 9 and 10, which are both located in the medulla. So we're on lateral and we're on medulla. The reason that it was not pons is that even though cranial nerve 5 itself should be in the pons, it says the sensory nuclei here. So we have a sensory nuclei and we have a motor nuclei. We're particularly talking about sensory nuclei here and sensory nuclei lateral. All right, medullary lesion. So that's one of the ways that you can isolate it. So you isolate all the symptoms and then put them together. We decided that the ataxia here was not a problem with the dorsal colon because it was preserved fine touch and proprioception. So this is lateral medullary lesion or lateral medullary stroke, Wallenberg syndrome. What you can see, and if we just do a little bit of that here, in Wallenberg syndrome, the things that are affected are, again, this is lateral medulla. So things that could be affected here, things that are on the side. So spinothalamic tract, so the patient will have decreased pain, a temperature sensation. Remember, this will be above the decussation, so this will be contralateral. Okay, with the spinocerebellar fibers are ipsilateral. So you have things like ipsilateral ataxia. The other structure on the side is sensory nuclei of cranial nerve 5. Sensory nuclei of cranial nerve 5. They will have decreased facial sensation, and this will be ipsilateral also. Ipsilateral. And then sympathetic fiber, so sympathetic nervous system. So this patient could also have ipsilateral Horner syndrome. So remember that Horner syndrome is when you have a lesion or compression of the sympathetic nervous system. And remember that the components of Horner syndrome are ptosis, meiosis, and hydrosis. So these are other things I see there. So Wallenberg syndrome, lateral medulla, this is when pica is affected. So you have a stroke of this vessel. All right, so that's one question. So let's do another one. The other question is, a 43-year-old woman with a past medical history of hypertension is brought to the emergency department. Her husband reports that on waking up 5 hours ago, she was unable to move or lift her right arm and leg. While you are performing cranial nerve examination, you notice a deviation of the tongue to the left. What is the most likely location of the lesion? So we are looking at, so unable to move or lift her right arm and leg. This is paralysis, right? So right arm and leg paralysis. And this is corticospinal tract, yeah? Corticospinal tract. And corticospinal tract is it a medial or lateral structure? So remember, four structures passing through the midline. Motor pathway is one of them. It's corticospinal tract. So this is the midline. All right. So what cranial nerve deficit do we have here? You notice the deviation of tongue to the left. So the tongue deviation is a deficit of cranial nerve 12. All right. This is hypoglossal nerve. Cranial nerve 12, hypoglossal, is what keeps tongue technically midline. All right. But the thing here though is when you have a deficit of either hypoglossal nerves, you have the tongue deviating to the side of the lesion, not opposite the lesion, to the side of lesion. So if the tongue is deviating to the left, the lesion is on the left. If the tongue is deviating to the right, the lesion is on the right. So the tongue points to the lesion. This is one of those cranial nerves that actually helps you determine if it's a right or left sided lesion. So we have the tongue deviation to the left. So this is the left sided lesion, right? Left sided. And that makes sense because we have said that the patient is unable to lift her right arm and leg. And we've established that with corticospinal tract, it will usually be a contralateral lesion. So if the patient cannot move the right arm and leg, it's a left-sided lesion. So these two things have come together to affirm each other. So left-sided lesion. So we have a lesion on the left side. But now we want to determine what part of the brainstem it is. So where is the hypoglossal nerve? Four nerves in the midbrain, four nerves in the pons, four nerves in the medulla. In the medulla, you have cranial nerves 9 to 12. The hypoglossal nerve is a cranial nerve 12. It's in the medulla. It's in the medulla. It's in the midline because we said the midline cranial nerves are divided into 12, 3, 4, 6, and 12. So this is in midline. So this is medial, right? So medial, from the 9 to 12, we would have only 12 will be medial. 9, 10, and 11 will be lateral. All right, which is how we got lateral medullary lesion or lateral medullary stroke here. So here we are looking at a medial medullary syndrome. How did we establish that it's medial? We saw that the corticospinal tract was affected, and this is a structure that runs medially. We saw that the cranial nerve 12 was affected, which is also a nerve that runs medially. How did we know that it was medulla? Cranial nerve 12 was affected. Cranial nerve 12 is located in the medulla. So medial medullary syndrome. The medial medullary syndrome is a syndrome that occurs when you have a lesion of the anterior spinal artery and sometimes even the vertebral artery. So this again, posterior circulation over here. This is anterior spinal artery. This is a vertebral artery. So, and this even makes sense. You can see that anterior spinal artery, which is the major one, runs in the middle. So it supplies the middle of the medulla, and you get something called medial medullary syndrome. So this is how somehow you figure out what part of the brainstem is affected. The third question is, what symptoms and signs, and this is the last thing, what symptoms and signs would you expect to see in a lesion of the anterior inferior cerebellar artery? What tracts and structures are affected? So the first thing to know is that ICAR, anterior inferior cerebellar artery, supplies the pons. Okay, so we check our vessel here. Okay, so this is medulla technically. So we have the pons here. So the anterior inferior cerebellar artery supplies the pons, and it particularly supplies the lateral pons. Okay, so lateral pons. So if we're saying that it supplies the lateral pons, now what are the structures that tracts and structures that we're expecting to see? So let's start with, we're saying it's laterally, right? So what are the structures that run laterally? Once again, structures to the side, spina cerebellar, spinothalamic, sensory nuclei of cranial nerve 5, and sympathetic nerve fibers. All right, so these are the major structures. Now, what other cranial nerves would we expect to see in the pons? So in the pons, we remember 4 cranial nerves in the midbrain, 4 in the pons. So we have cranial nerves 5, 6, 7, and 8. But we're talking about the lateral pons, right? In the middle, we would have cranial nerve 6 because it divides into 12. So 5, 7, and 8 are the cranial nerves that you would see that will possibly be affected in a lesion of the ICA. So now let's now bring all of that together to find symptoms and signs. So a patient that has a stroke in the ICA will have these possible symptoms. In the spinocerebellar tract, they would have ipsilateral ataxia. All right. Spinothalamic, they would have loss of pain and temperature sensation. Will this be ipsilateral or contralateral? This would be contralateral, right? Contralaterally. Sensory nuclei of cranial nerve 5, they would have facial numbness. Remember that our cranial nerves are usually ipsilateral. This is ipsilaterally. And then they would also have ipsilateral Horner syndrome. Now the cranial nerve deficit, with cranial nerve 8 vestibulocochlear, particularly the vestibular side of it, you would have things like vertigo, nystagmus. Cranial nerve 7, which is the facial nerve, they would have symptoms of lower motor neuron lesion of the cranial nerve 7. So if you remember this, so if you don't know this, with cranial nerve 7, you have 2 types of lesions, and it's one of the most commonly asked questions actually. There's upper motor neuron lesion and there's lower motor neuron lesion. And I don't want to make this video any longer than it already is. But remember that we always say that upper spares upper. So which means that when we talk about Bell's palsy is a lesion of cranial nerve 7 itself. It's not a cortical lesion, it's a lesion of the nerve itself. So with lower motor neuron lesion, upper spares upper. What that means is that when you have this numbness and motor disorder of the face, ipsilaterally, with upper motor neuron lesion, you tell the patient to puff their cheeks, you tell them to lift their eyebrows, you tell them to do all of that. With if it's an upper motor neuron lesion, it will spare upper. So they would still, when you tell them to do this, they would still have wrinkling of the forehead on that side. They might have the facial droop and they might have loss of facial sensation in the lower part of the face, but their wrinkling of the forehead will be spared. That's an upper motor neuron lesion, the cranial nerve 7. With lower motor neuron lesion of cranial nerve 7, they lose everything. So they lose wrinkling of the forehead on this side, they have the facial droop, they lose sensation, it's a complete paralysis of the affected side. So here you have lower motor neuron lesion of cranial nerve 7. So if you put all of the symptoms and signs together, these are the kind of things that you typically find when you have lateral pontine syndrome. All right, so this is it. So the idea again of the rule of fours is that if you've established that a patient has a brainstem stroke, you want to try to isolate what part of the brainstem is affected. How you do that is to pinpoint the tracts that are affected and also the cranial nerves that are affected. If you can bring them together, it's usually so much more easier. So once you bring all the symptoms and signs together, you're able to say, okay, we've established that this is a brainstem stroke, but is it midbrain? Is it pons? Is it medulla? We've established that now. Is it lateral or is it medial? So this is supposed to help with that. Particularly if you're preparing for the USMLE step one, this is a question that is always asked. They always ask questions on if you consider neurology high yield, there's always questions on brainstem strokes, and you have to be able to figure out what part of the brainstem is affected. PLAB 1, it's not so much heavily tested, but there are some questions in it and an MCCQE as well. So I hope that this was helpful. It's probably longer than I expected it to be, but I hope that this was helpful. If you have any questions, you can send it to me or you can leave a comment on the video itself. I'm hoping to be able to post more videos like this, maybe shorter. I'm not really sure yet, but I hope this was fun. I hope this was helpful. I'll see you guys some other time. Remember that if you want to book a one-on-one tutoring, you can do that on the website. If you need, if you have questions on the exams itself, consultations, you can do that on the website as well. And I look forward to seeing you guys. Thank you.